Bismillahirrahmanirrahim. Dear audience, Assalamu alaikum. I would like to thank my honorable teachers for arranging the presentation, and thanks to dear doctors of Unit Blue for joining. I am Dr. Mushtaq, intern doctor from M. Abdul Rahim Medical College Hospital, Dinaspur, Medicine Ward, Unit Blue. Today our topic of discussion is megaloblastic anemia. Here we goes to definition. Megaloblastic anemia is a type of anemia due to deficiency of vitamin B12, folic acid, or both. Folate is an important substrate of and vitamin B12 a cofactor for the generation of essential amino acid which is needed for hematopoiesis. This type of anemia is characterized by macrocyte in peripheral blood and megaloblast in bone marrow. In the picture, we can see the changes. The hypersegmented neutrophil. Here, the segment of nucleus is more than 5, and we can see megalocyte. All the proliferating cells may exhibit megaloblastosis. The changes includes in RBC and neutrophil change. In RBC, it is abnormally large and round, large oval shaped. In neutrophil, it is hypersegmentation. In the picture, we can see the metabolic relationship between vitamin B12 and folate. Here we can see vitamin B12 is working as a cofactor and dietary folate is the main substrate. If there is vitamin B12 deficiency, the folate in the form of methyl trihydrofolate may be trapped in the cells due to non-availability of vitamin B12. And this process helps in DNA synthesis and this helps in hematopoiesis. Then we can see the sources of vitamin B12, mainly animal source, includes mainly milk, meat, eggs, and fish. Our daily requirement is 1 microgram, but our daily average diet contains around 5 to 30 microgram, which covers our daily requirement. The absorption process of vitamin B12 includes in the stomach, the gastric enzymes releases the vitamin B12 at lower pH, and it is due to hydrochloric acid. Then it binds to carrier protein called R protein. After gastric emptying, here we can see, after gastric emptying, vitamin B12 switches to intrinsic factor in higher pH, which is controlled by pancreatic secretion. Then vitamin B12 in bile also be reabsorbed in the intestine. Vitamin B12 intrinsic factor complex is actively transported by enterocytes to plasma and then towards tissue, mainly in the liver for utilization. The liver stores enough vitamin B12 for 3 years, so vitamin B12 deficiency takes years to be manifested, even if dietary intake is stopped or malabsorption developed. Low vitamin B12 occurs in normal pregnancy, patients in myeloma, and women taking oral contraceptives. Causes of vitamin B12 deficiency includes it may be due to dietary problem. It occurs in strict vegans. Secondly, the stomach pathology due to hypochlorhydria, total or partial gastrectomy, carcinoma of stomach. Thirdly, we can see the pernicious anemia, and in this condition, there is gastric mucosal atrophy causing intrinsic factor deficiency. In the absence of intrinsic factor, less than 1% dietary vitamin B12 is absorbed. Fourthly, small bowel pathology, which includes ileal disease. We can see some names like Crohn's disease, ileal resection, which impairs the absorption of B12 intrinsic factor complex. Pancreatic exocrine insufficiency occurs in about 30% of the patients. Motility disorder can cause bacterial overgrowth and vitamin B12 deficiency, which is usually occur due to a competition to utilize the vitamin B12. And fish tapeworm named Diphyllobothrium latam can also cause vitamin B12 deficiency. Then we come to sources of folate. Daily requirement is about 50 microgram, which is produced by plants and bacteria. The rich sources includes leafy vegetables like spinach, broccoli, lettuce, peas, different type of cereal, and fruits like watermelon, bananas, and animal protein, liver, kidney. The process of absorption of folate is folate mainly remains in the form of polyglutamate, which is converted to monoglutamates in upper bowel. Then it is actively transported to plasma and binds with albumin. And there is enterohepatic circulation. Folate deficiency. Total body folate storage is small and deficiency can occur of weeks. Folate deficiency is more common than vitamin B12 deficiency because it is stored in small amount. Liver doesn't store it like as B12, and it is destroyed by heating during cooking. Causes of folate deficiency includes diet due to less intake of vegetables, increased demand, pregnancy, hemolysis. Some drugs may interfere, namely methotrexate, phenytoin, oral contraceptive pills. Malabsorption due to any cause like celiac disease, tropical sprue. Here we can see the changes in villi. In this type of disease, the villi got flattened. Clinical features of megaloblastic anemia, the symptoms are malaise, like illness, paresthesia, pricking sensation, sore mouth, breathlessness, weakness, weight loss, poor memory, depression, hallucination, visual disturbances. The signs are smooth tongue and angular chelosis, skin pigmentation, yellow tint skin, lemon yellow tint, vitiligo, heart failure, pyrexia. Neurological findings in vitamin B12 deficiency, and it is more important. It may include the peripheral nerves, spinal cord, cerebellar involvement, and autonomic neuropathy. In the peripheral nerve involvement, we can see the neuropathy. In the picture, there is globes and stalking pattern. Spinal cord causing subacute combined degeneration. There is loss of vibration, position sense, and upper motor neuron signs. In cerebral involvement, there is dementia and optic atrophy. We can see here the spinal involvement, subacute combined degeneration of the cord, means degeneration and demyelination of the dorsal, like posterior and lateral spinal column. And it occurs in vitamin B12 neuropathy. The posterior and lateral column is involved. Nerve fibers that control the movement sensations are damaged. People have general weakness, tingling, numbness in the hands and feet, and stiff limbs and may become irritable, drowsy, and confused. Then we will go for investigations in megaloblastic anemia. In CBC, hemoglobin percentage is reduced, MCV is increased, it may be more than 120, maybe pancytopenia. PVF shows macrocytes, hypersegmented neutrophils, poikilocytosis. Then bone marrow aspiration shows hypercellularity and megaloblasts. Serum vitamin B12 may be decreased. Serum ferritin and lactose dehydrogenase may be increased. Serum and red cell folate level may be decreased. In pernicious anemia, antiparietal cell and intrinsic factor may be present. Antibodies against parietal cell and intrinsic factor may be present in pernicious anemia. Management for vitamin B12 deficiency includes blood transfusion and therapy. Blood transfusion can be given in severe anemia. Then therapy includes injection hydroxycobalamin 1000 microgram intramuscularly in 6 doses for 2 to 3 days apart. Then maintenance therapy 1000 microgram every 3 months. Lifelong therapy should be given for pernicious anemia. Then management for folate deficiency 5 milligram folic acid containing tablet daily for 3 weeks, then 5 milligram weekly. Prophylactic folic acid in pregnancy should be given. It is normal and it is needed for neural tube formation. Also in hemolytic anemia, prophylactic folic acid may be needed. In initial response, if initial response is not maintained after giving the therapy, the blood film may be dimorphic, which includes both microcytic and macrocytic changes due to rapid depletion of iron storage. After therapy, iron is used more rapidly, and then iron therapy may be needed. In severe ill patient, treatment should be started with both folic acid and vitamin B12 without getting the investigation results, because folic acid alone should not be given if there is vitamin B12 deficiency, otherwise neurological findings may aggravate. Quotation of the day: Allah doesn't burden a soul beyond that it can bear. Surah Baqarah, verse 286. Thank you very much for your kind participation. Thanks for patient hearing. Assalamu alaikum.